Dr. Rizal Hamid sir, to please continue with your talk, sir. Thank you very much. So I'm sharing the screen. First of all, I would like to thank the organizers for giving me the chance of interacting with such a prestigious audience of this session. Myself, Dr. Rizal Hamid, and I'm going to discuss mild to moderate alcohol withdrawal syndrome. So here, especially, I will be stressing on role of fixed dose chlorodiazepoxide for effective management of alcohol withdrawal syndrome. So, as my previous learned speakers has already discussed about the burden of alcohol use disorder and its neurobiology and the various aspects of pharmacological management. And so, my this presentation would be restricted to mild to moderate form of alcohol withdrawal syndrome, with special emphasis to chlorodiazepoxide only. The main goal of management of alcohol withdrawal syndrome is to decrease the symptoms and prevent occurrence of life-threatening symptoms of later stages of alcohol withdrawal like seizures, delirium. Sometimes in alcohol withdrawal, we may see patient suddenly developing very serious form of infection, may go to septic shock, and very critical situation may arise. So beside management, we also there's also involvement of treating the underlying disorders, and underlying disorders could be mostly the underlying psychopathologies, and and it is to be kept in mind that there is the possibility of something lying beneath, that is the behind the alcohol addiction. There could be some serious form of mental illness. It could be of anxiety, it could be depression, bipolar, or any other form of mental disorders, and that is to be kept in mind. And while doing this process of alcohol de-addiction, we have to keep in mind that we also have to minimize the risk of new drug dependence. Benzodiazepines represent the first-line treatment for management of alcohol withdrawal symptoms, and they modulate anxiolysis by stimulating GABA A receptors. And it is to be mentioned that these are the cross-tolerant with alcohol. Among various benzodiazepines, chlorodiazepoxide has emerged as the preferred drug for the management of alcohol withdrawal syndrome, and given its faster control of withdrawal symptoms and very favorable tolerability profile. So here I'm here with a case of 46 years old individual, reports to the psychiatric outpatient department with symptoms like agitation, trembling, severe headache, and vomiting. So his history was like this: that patient had the alcohol dependency in past 2 years, and after the demise of his wife, and he was also having a high blood pressure and was on regular medications. His personal and professional lives are greatly affected due to the improper functioning due to his alcohol taking behavior, and the patient opted for medical treatment by himself, since only the motivation and counseling has been ineffective for him. And so on general examination, he was afebrile, but he was having tachycardia. His heartbeat was 130 beats per minute. He was hypertensive, and he was on laboratory investigation. His serum sodium found to be at lower level, with mean corpuscular volume to be 80 FL, blood urea nitrogen, serum creatinine, etc. were normal. His ALT was normal, but his GGTP was moderately raised, where the level is 70, and he was having 200, and his bilirubin level, serum bilirubin level, was 1.2 milligram per deciliter. So the patient was diagnosed as mild alcohol withdrawal syndrome, and it was a plan to manage this patient as the outpatient basis. And it is to be mentioned that when It is always danger to manage the patients at the outpatient basis, as the patients of alcohol withdrawal can manifest as very serious form of withdrawal seizure, or may go into delirium tremens, and very serious form of consequences may occur. And usually, it is advisable to manage this size of patient with an HD facility or a nearby ICU facility. So, as this case was a very mild form of alcohol withdrawal, his management was done as initial supportive therapy, and his correction of the electrolyte imbalance, and it was with mild form of electrolyte imbalance, and was corrected very well with oral rehydration therapies. And his environment was controlled. Patient was advised to keep in a bit quiet and low lighting uh, room, and to avoid any further stimulation. And on treatment of medication here, what the most important thing I would like to highlight is that I would like to show the beauty of chlordiazepoxide, and it can be given 100 milligram per day in divided doses for 3 days. And simultaneously, we should go for the vitamin B supplementation, thiamine 100 milligram per daily. My learned previous speaker has already talked about warning encephalopathy, the delirium tremens, and so these are to be kept in mind. And simultaneously with B complex, we should include folic acid 400 microgram, and follow up after 3 days. And on the third day of follow up, there was significant improvement of withdrawal symptoms, including his agitation was minimized, he was stabilized in terms of overall clinical investigation, and patient reported nausea of mild intensity. And during the further follow-up, the patient was advised to continue chlordiazepoxide treatment with gradual tapering of the doses, like 25 milligram 3 times a day for next 3 days. That means the total dose of 75 milligram per day, then 25 milligram twice daily for 3 days, and that is the 50 milligram per day, and gradual tapering of the doses. So in this case, what we can see is that the benzodiazepines could have been the right choice for the treatment of management of alcohol withdrawal, mild to moderate form of alcohol withdrawal syndrome. The initial drug should have a rapid onset. What is expected is that the drug should act very rapidly, and it should have a long duration of action, and that is the chlordiazepoxide is having, with a wide margin of safety. Both is pharmacokinetically and pharmacodynamically, it should be safe, because the patient of alcohol may have very wide range of both psychiatric and physical comorbidities. And also we have to consider there is a potential of abuse. And long-acting benzodiazepines are the drugs of choice for alcohol detoxification, and because their blood levels are relatively stable and reduce the risk of rebound symptom. What is the most important thing is that the rebound symptoms, and that is the mechanism of getting the withdrawal seizures. And chlordiazepoxide is a long-acting benzodiazepine with greater half-life, that is the 24 to 48 hours, and has uniform blood level throughout the day. Thus, it is associated with very reduced risk of alcohol withdrawal seizure, and which may occur because of drop in blood level of the drugs. And the treatment regimen for treating alcohol withdrawal include the gradual tapering of the dose approach, fixed schedule approach, and symptom triggered approach depending on which symptoms. And the outpatient treatment with fixed dose approaches offer simplification of the dosing schedule, along with better margin of safety and patient compliance. And this is only applicable for a mild to moderate form of alcohol dependence, without any physical and other psychiatric comorbidities. So chlordiazepoxide provides a faster and smoother withdrawal course with lessened breakthrough or rebound symptoms of alcohol withdrawal. The clinical studies of chlordiazepoxide for management of alcohol withdrawal has demonstrated the many benefits, like reduction in agitation, irritability, and mostly associated with alcohol withdrawal seizures. And Prevention of critically severe form of alcohol withdrawal, like withdrawal seizures or delirium. These symptoms can be well prevented by chlordiazepoxide, and further it is well tolerated with very less risk of drug discontinuation reactions and less abuse potential compared to other benzodiazepines. And studies also proves that it is greater patient satisfaction, and which is the rate of 82%. So here is about the nice guideline of 2019 for assisted alcohol withdrawal, and the recommended treatment regimen for the outpatient withdrawal, that is the fixed dose approach, and that is the preferred medication is chlordiazepoxide or diazepam. And recommended treatment regimen is the initial dose of medication is titration to severity of alcohol dependence and or regular level of daily alcohol consumptions. And follow up, while the follow up, the dose is reduced to about 7 to 10 days to avoid alcohol withdrawal recurrence. And lower dose, some minimum dose is to be maintained for several weeks. So in this case, what the key highlight we can see is that this chlordiazepoxide in alcohol withdrawal, that is the faster and smoother withdrawal it gives. And it prevents severe rebound symptoms, and it is having the very less abuse potential. And it gives a better patient satisfaction and better patient compliance. So with this small presentation, I declare this presentation to be over and hand over the mic to the organizers.
Thank you, sir. So
So I have stopped sharing.